Everyone, very good evening to all of you. Am I clearly visible, audible, everything is good to go? Can you confirm in the chat box if everything is good to go and we can start the session? I guess yes, it's working. Yes. So I welcome you all for today's session, and today we are having a very important session. I mean, we are going to discuss super duper important topics in pharmacology. We have already started our integrated central nervous system, and we have already covered entire pathology, entire microbiology, and it's time to continue with the pharmacology. In the pharmacology also, yesterday we have already started the drugs acting on central nervous system. Today I am going to continue it. So today I will be discussing two ultra important topics over here, that is anti-Parkinsonian drugs and anti-epileptic drugs. It will be a super conceptual session. Okay, today I will show you many videos to understand the mechanism of action of the drugs and the pathogenesis of the disease. Okay, so it's very interesting. I will teach you anti-epilepsy drug in the form of the videos. I mean, there are 8 types of epilepsy. I will show you video for all of them later on. First, we will start with anti-Parkinsonian drugs. Okay, so can we start? Chalo, give me a thumbs up. Hi, Dr. Lone. Hi, Dr. Kanu. Can we start? Chalo, let's start it. Let me share my screen first. Okay. I guess you can see my screen now. So let's start. So I am starting with integrated central nervous system. In the integrated central nervous system, we have already completed all the central nervous system disorders. I assume that you have already watched it. All the CNS tumors I have completed there. I have already completed CNS infections. All the CNS infections are completed in microbiology. All bacteria, virus, fungus, parasite. I taught you 24 organisms there. Each and every organism detail is already there. And we have already started pharmacology. In pharmacology, we have started drugs for central nervous system. Let's continue it. So this session is pharmacology session. Can we start it? People kindly respond. Chalo. So let's start it. The drugs acting on central nervous system. As I told you yesterday, these are the topics we have to complete in this system. Okay, we are having 3 episodes. One is already done, in which we have completed sedatives and hypnotics and alcohol. Today is episode 2, in which the planning is we will complete anti-Parkinsonian drugs and anti-epileptic drugs, because both the topics are very big. Okay, so we will be able to cover these two. Tomorrow, we will be covering antipsychotic, anti-mania, antidepressant, anti-anxiety along with opioids. And after that, general anesthesia, and we are having local anesthesia also in the PNS. Both the anesthesia I will upload as a recording. Okay, so in this way, the complete CNS will be done. Okay, so currently, pay attention on the 2 topics I am going to teach you today, ultra important. Let's start with anti-Parkinsonian drugs. Okay, anti-Parkinsonian drugs, my first topic for today. So what is anti-Parkinsonian drugs? As the name indicate, anti-Parkinsonian drugs. These are the drugs which act against the disorder Parkinsonism. So can you understand these drugs? I don't think so, unless and until you understand the disorder Parkinsonism. So before I teach you the drugs, I will teach you as usual pathology of the disease. So if you understand why Parkinsonism occur, how Parkinsonism occur, we can understand the mechanism of action of the drugs very easily. So before I start the pharmacology and teach you the various drugs which help in treating or managing Parkinsonism, we have to understand the pathogenesis of Parkinsonism. So let's start Parkinsonism. For the first 10 minutes, we will be discussing Parkinsonism. So let's start it. What is Parkinsonism? What is Parkinsonism? Give me a minute. Am I live now? Everything is visible, audible, good to go, right? Okay. Right, I guess. Okay. So what is Parkinsonism? Parkinsonism is a progressive degenerative disorder of the brain, of the basal ganglion of the brain. Okay. It's a progressive degenerative disorder. It mainly affects old people. The most common age of Parkinsonism is 45 to 65 years of age. Okay. James Parkinson was the scientist who first time described it. What this scientist have described? This scientist have described it's a paralysis agitans, or it is known as shaking palsy, long ago. Okay, and that's why, to honor the scientist who described the first case of this disease as a shaking palsy or as a paralysis agitans, we honored the scientist. And that's why we named the disease as Parkinsonism. So actually Parkinson is the name of the scientist. So what is a disease? Actually, what is happening in this disease? In this disease, there is a neurodegenerative disorder. Neurodegeneration takes place, especially basal ganglion of the brain. I will explain in detail. Here there is a triad. Patient of Parkinsonism presents with 3 symptoms. What are the 3 symptoms? Patient typically presents with 3 symptoms. What are the 3 symptoms? Patient presents with tremor, with rigidity, and with hypokinesia. Patient presents with 3 symptoms: tremors, rigidity, and hypokinesia. I will explain. So this is the main triad. I will explain all 3. I will show you the videos of all 3 rather. Okay. Along with that, there are secondary manifestations, like there is posture, change in posture, defective gait. There is no expression on the face, mask-like faces. Okay, normally we have expressions on our faces, but here there is no expression on the face. Okay, styloria, excessive salivation in the mouth, dementia, loss of memory. Okay, and these all can also happen. They are not included in triad. In the triad, we are having 3 symptoms. What are the 3 symptoms? First of all, there is tremor. Second, there is hypokinesia, also known as bradykinesia. Hypokinesia or bradykinesia. And third, there is rigidity. Let me explain. You can see this man, old man. The most common age is 45 to 65. Can you see the shaking hands and shaking legs? Can you appreciate the shaking behavior? Appreciate. These are tremors. So first of all, appreciate this tremors. Okay. Number 2, appreciate the posture. The posture is due to rigidity. Okay. You can appreciate the posture is due to rigidity. Tremors are there, rigidity is there, and bradykinesia you cannot appreciate. The motion is slow. It is bradykinesia or hypokinesia. I will show you again. So you can again see there is an old man. So see the brain of the old man. In the brain of this old man, there is a neurodegenerative disease. Neurons are degenerating. Which neurons? I will let you know. In the basal ganglion, the dopaminergic neurons will be degenerated. It will lead to a triad. Number 1, you can appreciate the hands are shaking. That is known as tremors. Number 2, you can see rigidity is there. Okay. And number 3, bradykinesia. I will show you the videos. So let's start one by one. What are tremors? The tremors are seen only at rest. Okay. They are not seen at movement. They are not seen during sleep. Suppose I am resting my hands. Okay. And I am having the Parkinsonism. So at rest, I will have the tremors. But if I do anything activity, the tremors disappear. During sleep also, the tremors disappear. It's a very unique thing. And they are increased by anxiety or stress. So tremors appear at rest. Have a look. The tremors are like this. The Parkinsonian tremors. Appreciate it. Appreciate it. Okay. They are at rest. They are at rest. Appreciate the small tremors if you can appreciate it. They are at rest. So tremors appear at rest. Yes. Okay. They disappear at activity or movement. They disappear during sleep. Okay. And they are increased with anxiety and stress. With anxiety and stress, they increase. Learn the properties of the tremors. These are the properties of the tremors in Parkinsonism. Second is hypokinesia or bradykinesia. The meaning is same. Hypokinesia, bradykinesia. I mean slow initiation of any voluntary movement. Suppose I want to do any voluntary movement. I want to raise my hands. So I'm raising my hands quickly. But if the person with Parkinsonism want to do any activities like raising the hand, so the initiation will be very slow and then it will be sudden. So there is no smoothness in the movement. Normally, if I'm doing anything, see, I'm having smoothness, the smoothness of the movement. Here, there will be no movement. The initial part of the movement is very slow and the later part will be gradual. Later part will be sudden. So this is hypokinesia. I will show you. Because of the hypokinesia, the gait is also abnormal. So as soon as you leave the patient will fall behind. Patient cannot initiate the steps ahead. Okay, that is due to bradykinesia. You can appreciate. Okay, as soon as we are leaving the support, patient cannot take the next step. Okay, bradykinesia. The third is the rigidity. What is rigidity? You know what is rigidity? Increased resistance to passive movement. Suppose we are doing a passive movement. Suppose I am losing my complete tone of hands and you are holding my hands and doing like this. I don't have any resistance. No, I'm just losing my resistance. Passively, I'm losing my resistance and you can do like this or you can do any movement. But here the person have lost the complete tone. But still, when we are doing any passive movement, appreciate the examiner. The examiner is doing the passive movement in the patient. Okay, you can appreciate. On passive movement, patient is giving resistance. This is rigidity. So there is rigidity in movement due to increased muscle tone. The muscle tone is increased. The basal muscle tone is increased. So that is known as rigidity. Okay. Because of which, again, there is postural defect. Patient is unable to maintain the right posture. And patient is having fascinating gait. What do you mean by fascinating gait? Patient walk more rapidly because patient think that I will fall down. He cannot still stand up. Suppose we stand up, we can still stand up now. Patient cannot stand up. He keep on walking. Try to keep walking fast, rapid, and try to take the small steps, as he is chasing his own center of gravity. This gait is known as fascinating gait. I will show you this, okay. And patient is bending forward. You can see. Okay, patient is bending forward. You can appreciate. The patient is bending forward, number one. Okay, and patient is taking small steps, baby steps. Patient try to find out his own center of gravity. And patient is taking small steps, I agree. But patient is walking very fast. If the patient do not walk, he fell down. That's why he keep on running, keep on walking, but small steps, because he don't have the balancing. Okay, this gait, this typical gait, you can see one more video I'm having. Appreciate. The patient is taking small steps like that. Can you appreciate these videos? This is known as fascinating gait. Appreciate, people. So tell me the triad. People, tell me the triad. What is the triad of Parkinsonism? Parkinsonism. Tell me the triad. Who will tell me the triad? What are the three features? The patient presents with tremor. The patient presents with hypokinesia or bradykinesia. And patient presents with rigidity. I have shown you the videos of all three and you can learn their features. The tremors appear only at rest. Tremors do not appear in activity. They do not appear during sleep. They increase in anxiety. They increase in stress. Hypokinesia or bradykinesia is initial part of the movement is very slow. Okay, and because of which abnormal gait. Rigidity, there is resistance in passive movement. That is known as rigidity. So because of both of them, the abnormal gait is there. And the abnormal gait is known as fascinating gait. Can you describe the gait? Patient is bending forward, taking baby steps and taking rapid steps, chasing his own center of gravity. People respond. Got it? Can I tell you the pathogenesis of Parkinsonism quickly? So let me tell you the pathogenesis. How does Parkinsonism occur? Let me tell you the pathogenesis of Parkinsonism. Listen here, everyone. So Parkinsonism is a disorder of basal ganglion. It is not complete basal ganglion. In the basal ganglion also it's substantia nigra and nigrostriatal tract. Inside the basal ganglion, to be specific, to be pinpoint, it's not complete. It's a disorder of basal ganglion. It's a generalized thing. Inside the basal ganglion, it's substantia nigra and nigrostriatal tract. Okay, inside them, the dopamine containing neurons are degenerated. Okay, not acetylcholine containing neurons. Okay, not glutamate containing neurons. There are three types of neurons inside basal ganglion. I will let you know. Out of the three, dopaminergic neurons are gone. Okay, so there is an imbalance between the inhibitory and facilitatory system. Let me tell you, listen here, listen. Let me tell you how many type of neurons are there. See this diagram, see this thing. In the basal ganglion, there are three type of neurotransmitters. Appreciate here. You can appreciate in the basal ganglion, you can appreciate, not in the basal ganglion, you can appreciate the striatal tract. This is a neuron in the striatum. Appreciate, this is a neuron in the striatum. It is receiving three type of signals. One is from the glutamine, okay, one is dopamine, and one is cholinergic. You can appreciate here glutamine is coming, you can appreciate here dopamine is coming, and you can appreciate here acetylcholine is there. So you don't have to understand this track. People, it's very complicated. You don't have to understand. You have to understand there are three type of neurotransmitter exist in the basal ganglion. What are the three types? Out of the three types, this glutamine is excitatory in nature. Okay, dopamine is both. Okay, there are two type of dopamine actually, D1 and D2. D1 is inhibitory, D2 is excitatory. So it's both, but inhibitory one dominate. So overall, if you see the net effect of both of them, it's inhibitory. That's why I have written the word modulatory. It's excitatory as well as inhibitory. D1 is excitatory, D2 is inhibitory, but overall the net is D2, okay, and the net will be inhibitory. So dopaminergic is not only inhibitory, but net effect is inhibitory. And what is the third? Acetylcholine. One is excitatory, one is both, but predominantly inhibitory. Acetylcholine is balancing neurotransmitter, okay, it facilitating or balancing neurotransmitter. It's a balancing or facilitating. What do you mean by balancing or facilitating? Let me explain. Okay, listen, I'm doing any movement. See, this is my movement. Appreciate the smoothness. Okay, in this movement, I'm doing contraction of my muscle, I'm doing relaxation of my muscle. Okay, so contraction is due to excitatory neurotransmitter. Okay, relaxation is due to inhibitory neurotransmitter. So I can do contraction, I can do relaxation, but appreciate the smoothness. Smoothness is due to the third neurotransmitter, that is balancing neurotransmitter. You are getting my point? So for doing any movement, whatever movements we perform, there is excitation, there is inhibition, and there is smoothness. There is balancing. You are getting my point, what I mean? So there are three neurotransmitters. Okay, the glutamine, you can see here. The first one, you can see the glutaminergic neurons. They cause contraction, excitatory. Okay, the dopaminergic are inhibitory. They cause inhibition. Okay, and the third one, acetylcholine, they do the smoothness. Okay, so normally in a healthy human, inside the basal ganglion, dopamine and acetylcholine are equal and opposite. Okay, both are equal and opposite. I will call this one inhibitory, but this is not always inhibitory. Actually, dopaminergic neurons are of two types, excitatory, inhibitory. The net effect is inhibitory. Again and again, I'm repeating. Okay, and here this one is the facilitatory. Okay, normally in normal state, both of them cancel each out. Okay, suppose there is a disorder in which dopamine is more and acetylcholine is less. Okay, dopamine is more, acetylcholine. So such disorders are known as hyperkinetic disorder. Okay, and reverse. Okay, if dopamine is less and acetylcholine is more. So currently my topic is hypokinetic disorder. So in Parkinsonism, this is the scenario. So basically what is happening in the Parkinsonism? Say again. What is happening in the Parkinsonism? There is degeneration of the neurons in the basal ganglion. In the basal ganglion, which neurons are gone? There are three types of neurons. Na? Glutamine neurons? No. Is it acetylcholine neurons? No. Which one? It is dopaminergic neurons. So the dopaminergic neurons are gone. They are degenerated. The dopaminergic neurons are degenerated. Okay. Since the dopaminergic neurons are gone, so dopamine is less. The inhibitory neurotransmitter is less. Okay, and cholinergic will be relatively more. Facilitatory system will be more. So there is an imbalance between the two. And this imbalance leads to the disease Parkinsonism. How many of you got it? Give me a thumbs up. Okay, now the question arises. You should ask me a question, ma'am, how does the degeneration is taking place? Who is causing this degeneration? I understood that in the basal ganglion, there are three types of neurons. Okay, the one which contain glutamic acid, the one which contain dopamine, the one which contain acetylcholine. You are saying that these neurons are gone. So there is an imbalance between these two. Normally, these two are equal and opposite. There is an imbalance between the two because dopaminergic is gone. But who is causing this damage? It is iron. It is iron. You know, inside the basal ganglion, abundant of iron is automatically present. Inside the basal ganglion, abundant of iron is already present. Okay. Now, this iron in presence of this iron causes the oxidation of dopamine. In the basal ganglion, we have dopamine also. This iron, okay, causes the oxidation of dopamine, and for doing so, the iron convert to free radicals. The free radicals are formed. Okay, iron is forming free radicals because of oxidation of the dopamine. Okay, so in the basal ganglion, we have dopamine. In the basal ganglion, we have iron in ferrous state. So this iron causes oxidation of dopamine, and because of which free radicals are formed. These free radicals in healthy young adult, okay, in young adult, God has given us glutathione. Glutathione is an enzyme which destroys the free radicals. We don't have to worry. But in old age, this glutathione is not present. Its concentration decreases. That's why the free radicals which are formed, they are not managed. And these free radicals will attack the dopaminergic neurons. The dopaminergic neurons are gone. And there is an imbalance between acetylcholine and dopamine. So dopamine will reduce, acetylcholine will increase, an imbalance will occur, and that will lead to Parkinsonism. You have to understand this. If you understand this, then only you will be able to understand the drug. Anyone who have any confusion, kindly do ask. So you can see here, in normal state, I am saying the dopamine is equal to acetylcholine. Okay. Currently, I am teaching you a disorder in which dopamine is less and acetylcholine is more. And the name of the disease is Parkinsonism. Who is causing the destruction of the neurons containing dopamine? It is iron. present in the basal ganglion, the parastate iron. This iron causes oxidation of dopamine. While doing so, free radicals are generated, and these free radicals causes the damage of these neurons. Say people, say, kindly respond. Otherwise, I will also speak monotonously, okay, without any interest, like you people are sitting without any interest. Say, do you have any confusion? Otherwise, let me know. It's a very interesting topic. I'm super excited today. Can't you see? Chalo. So normally inside our basal ganglion, God has given, the great God has given dopamine is equal to acetylcholine. Suppose both of them are 100. Okay, this is normal situation. But in Parkinsonism, there is the imbalance between the two. What is the imbalance? Due to the imbalance, I mean due to the degeneration of the dopaminergic neurons, dopamine is less. Acetylcholine is same. It's still same. Okay, so it is relatively more. I will not say it's more. It's relatively more. Okay, acetylcholine नहीं बढ़ रहा, ये उतना ही है. लेकिन चूंकि dopamine कम हो गया, so acetylcholine ज़्यादा है. It's relatively more. So this is imbalance, and this imbalance leads to the disease Parkinsonism. So this is the scenario. This is the scenario. So what I said, who is causing destruction of these neurons? Can anyone tell me? You have to understand it. It is iron. How iron is causing? Iron directly causing? No. Iron will form free radicals. How iron will form free radicals? Iron causes oxidation of dopamine with the help of MAO-B enzyme. And during this process, the free radicals are formed. And these free radicals will cause a destruction. Say, ma'am, why it is not causing destruction in young? Because in young people, we are having an enzyme, glutathione. This glutathione destroy the free radical. Free radical to abhi bhi ban rahe hain. In me also, in you also, we all have formation of free radical. I think I'm also still in middle aged, not old. Okay. So yes. So in me, in you, glutathione is still present. So this free radical is formed in my basal ganglion also, in here also, but don't worry, we have glutathione. But maybe in old age, whenever we all are 70, 80, 90 years old, if we survive till then, so this glutathione will fall. Okay, so free radical to tab bhi banega, but at that time it will not be managed, and this free radical will cause the damage of the dopaminergic neuron, and the person can have Parkinsonism. So this is the pathogenesis. If you understood the pathogenesis, this is the summary of the pathogenesis. Okay. Acetylcholine is balancing. Okay, but it is facilitatory. No, it is not. I will not call it excitatory. Excitatory is glutamic acid, COMT. Excitatory, there are total 3 neurotransmitters in the brain. I cannot change their role. Dopamine is both excitatory as well as neuroinhibitory, but the net effect is inhibitory. The complete schematic diagram is very complex. You don't have to go in the detail. You have to say the facilitatory acetylcholine. You don't have to say excitatory. Okay. In Parkinson's disease, this is the summary. In Parkinson's disease, it's a disease of brain, first of all. In the brain, it's a disease of basal ganglion, the second thing. In the basal ganglion, it's a disease of substantia nigra. Substantia nigra par recta. Okay, substantia nigra, in which the dopaminergic neurons are damaged with the free radicals. The free radicals are formed from iron by oxidation of dopamine only. These free radicals are damaging the dopaminergic neurons. So there is an imbalance between the dopamine and acetylcholine. This results in the triad of Parkinsonism. It results in 3 things. Person have hypokinesia, rigidity, and tremors. Okay, this is the disease Parkinsonism. This is the disease. You can see dopamine is less, acetylcholine is more. Normally they are balanced. Okay, you can see dopamine is less, acetylcholine. Don't go on the numbers. It can be any number depending on the severity of the disease. At very severe disease, dopamine may be nearly 0. Nearly. Okay, at severe disease at which the person dies. Okay, so it depends on the severity of the disease. Acetylcholine is constant. Don't go on the numbers. Numbers are just to show you. Okay. So the same thing I want to show you in the form of numbers. Here I have shown you. Okay. So what is the treatment? What is the treatment? What is the treatment here? Say what you want to treat here. Say, ma'am, the problem is imbalance now. Balance it. The patient will be treated if you balance it. How to balance it? There are 2 ways to balance. The main problem is with dopamine. So say, ma'am, increase dopamine. If by any way, by giving some treatment, you can increase the dopamine, the balance will be achieved again, and patient will have the reduced symptoms or no symptom, symptomatically improvement if we can increase the dopamine. Or else, if you can't increase the dopamine, decrease acetylcholine also. See, ma'am, there is no problem with acetylcholine. Why you are decreasing it? I want to make the balance. The main point is balance should be there. If there is a balance between the two, now the movements will be smooth. Otherwise, there is tremors, there is rigidity, there is hypokinesia. Movements are not smooth. The smoothness of the movements is gone because there is imbalance. The problem is imbalance. So there are two ways to treat. The main treatment, I agree, the main treatment is to increase dopamine. The secondary treatment is to decrease acetylcholine. We can try both also together. Okay. So ultimately we want to achieve a balance over here. Say people say, what is the aim of treatment? What is the aim of treatment? Glutathione we can't provide, Jayashree. If we can provide glutathione, it's an anti-aging enzyme. It is the only enzyme which is deficient in the old age, and that's why it leads to aging. Why we all get aged? What is aging? Aging is a natural phenomenon. It's not a disease. We all get aged. Imagine if we have artificial glutathione. Imagine. Okay. None of us become old. We all remain young forever. Okay. How beautiful the life is, na? If we have the artificial glutathione. But unfortunately, we can't do that. Okay, chalo. So what is the aim of the treatment? Say, what is the aim of the treatment? The aim of the treatment is two. The main aim is to increase the dopamine. Okay. And the secondary aim is to decrease cholinergic. I mean, decrease acetylcholine. See, remember, there is no problem. The cholinergic pathway is not primarily affected. There is main problem in the dopaminergic pathway, which is reduced. Why you are hitting the cholinergic pathway? Because suppression leads to restoration of the balance. I agree this is not the culprit, but if I reduce it, the balance will be achieved. If the balance will be achieved, the smoothness will be regained. People say now, you are getting it. So I will treat Parkinsonism with two ways. Number one, with any modality, with any drug, I will try to increase the dopamine, or else if I can't do so, I will decrease the acetylcholine. Okay, main problem here is degeneration of dopamine. Normally in our brain, in our basal ganglion, in our substantia nigra of basal ganglion, brain, basal ganglion, substantia nigra of basal ganglion, dopamine and acetylcholine are equal. Okay, this one is inhibitory neurotransmitter, this one is facilitatory neurotransmitter, and they give smoothness of our movements. Appreciate the smoothness of my movement. My movements are very smooth. They are not like haphazard, okay, jerky, chorea. No, it's not like that. They are smooth, voluntary. If I want to contract a muscle, I'm contracting. If I want to relax a muscle, I'm relaxing. They are smooth. This is due to the three neurotransmitter. One inhibitory, that is dopamine. One facilitatory, that is acetylcholine. And third is excitatory, that is glutamine, which is not involved here. You are getting my point. In Parkinsonism, okay, in the basal ganglion, in the brain, in the basal ganglion, iron is naturally present. It's present in the basal ganglion. Iron, God has given the iron there. Iron is present there. This iron and dopamine is also present in the basal ganglion. Okay, this iron causes oxidation of dopamine. Okay, which causes production of free radical, and this free radical causes damage to the neuron containing dopamine. This free radical hit only neuron contain dopamine. It don't hit the neuron contain acetylcholine or glutamic acid. You are getting my point. So only dopamine containing neurons are lost. Neuron ka neuron hi chala jayega. The complete neuron is lost. So since the neuron is not there, dopamine is not there. Dopamine is not there, so dopamine will be relatively less. Acetylcholine is still same, but dopamine is less. So there is an imbalance, and this imbalance is leading to non-smooth movements. Okay, normally the movements are smooth. Here, non-smooth movements. So three things will happen. Patient will have tremors. Number one, patient will have rigidity in the passive movement, and patient will have hypokinesia or bradykinesia. I mean, the starting of the movement will be slow. So starting part of any movement will be hyper slow, and after that a sudden shoot will be there. So this will happen. So that is the triad of Parkinsonism. Okay, everyone got it? Anyone have any confusion? Can we start? Let's come on the drugs now. You are ready to start the chapter. Let's start the drugs of Parkinsonism. Here you can see the drugs of Parkinsonism. Everyone, the drugs. Okay, there are two types of drugs, as I told you, the two main aims. Number one, we can give the drugs that act on dopaminergic system. That will increase the dopamine. That will act on dopaminergic system. Or we can give the drugs that acts on cholinergic system. That will decrease the acetylcholine. Okay, these are not main, the acetylcholine one. The main drugs are dopaminergic. Dopaminergic mein we have six main categories. Six main categories. What are the six main categories? We are having dopamine precursors. Okay, we are having peripheral decarboxylase inhibitor. Okay, we are having dopaminergic agonist, MAO-B inhibitor, COMT inhibitor, and glutamate antagonist. These are the six which are acting on the dopaminergic system. I will teach you all six in a master table. And that side we have only one. We are having antihistaminic, but we will not study that. The main is anticholinergic. What are anticholinergic? Anticholinergic are the drugs that inhibit acetylcholine. So total 7 drugs, people. 1, 2, 3, 4, 5, 6, 7. 7 drugs I want to teach you. Out of the 7, the first 6. 1, 2, 3, 4, 5, 6. These 6 acts on dopaminergic system. They increase the dopamine by any way. Okay. And the last one, act on acetylcholine, cholinergic system. That is anticholinergic. It inhibit acetylcholine. I hope you got the classification broadly. Say, I hope you got the classification broadly. Okay, so let's start these drugs one by one. Among these 7 categories, the most important, which we have to study in much detail, is dopamine precursor. Only one drug it is having, the dopamine precursor, Levodopa, the ultra important drug we have to study. Okay, we have to study all, but this one in detail, I mean. So you can see the 7 categories I have made. The first 6 categories are acting on the dopaminergic system. Dopamine precursor, peripheral decarboxylase inhibitor, dopaminergic agonist, MAO-B inhibitor, COMT inhibitor, okay, glutamate antagonist, and last one is central anticholinergics. Let's start it. Let's start with the first drug. Be ready. Chalo, take out your notebooks, take out your pen, and be ready to fill the 7 categories. This one is big. It will take 20 minutes. The remaining are small. They will take 5-7 minutes. Quickly, we will finish this chapter and come on the next one, antiepileptic. Okay, that one is even more interesting than this. So let's start the drugs. The first drug I am starting, the first drug, the ultra important. Take out your notebooks, people. Fill dopamine precursor under a fixed set of heading. You know my set of heading. So dopamine precursor. First, I will let you know the classification, then introduction, mechanism of action, actions, pharmacokinetics, interaction, uses, adverse effect, and contraindications. Okay, let's start it. Dopamine precursor. So let's come on the classification. We have only one drug over here. What is the name of the drug? Levodopa. Okay, keep interacting, people. Keep writing. The chat box should be running. Okay, so the classification, only one drug, Levodopa. Come on the introduction. There is a problem. People, listen. Use your common sense. Now see this diagram. This is the master chart in which I will teach you total 7 drugs. All 7 drugs are written here. You can see all 7, the drugs, anti-Parkinson drugs, which I am going to teach you are over here. All 7 category. You have to understand it. You have to understand. Here, this side I have shown you the blood vessel. This is the blood vessel of a human. Okay, whatever present in the blood vessel, it cannot go inside the brain. This is brain. Appreciate this is brain. Okay, you can appreciate the diagram like this. This is blood vessel, this is brain. But I have not drawn like this. I have drawn 2 boxes. This is blood vessel, this is brain. This is brain. But whatever present in the blood vessel cannot go in the brain. It has to cross BBB. It is blood-brain barrier. You are getting my point? So this is a blood vessel of a human. This is the brain of a human. But there is a blood-brain barrier. BBB is there. So the substances which can cross BBB, that only reach inside the brain. Otherwise, other substances cannot reach inside the brain. Okay, only one portion of the brain which is not covered with BBB is CTZ. You know, CTZ is a portion which is not covered by BBB. Otherwise, the complete brain is covered with BBB. So whatever substances present here, they can expose to CTZ, but for the brain, for reaching the basal ganglion, the main hit here is basal ganglion. It has to cross the BBB. You are getting my point? Say yes, say no. Now use your common sense. What is the problem in Parkinson's? Say, ma'am, in Parkinson's, you told us the problem is that inside the brain, inside the basal ganglion, the dopamine is less. Okay, now I will use my common sense. Okay, not a doctor's brain, a simple common sense. Okay, so why don't we give dopamine, ma'am? Simply give dopamine. Dopamine will go and it will get replenished. Whatever deficiency is there, we are replenishing it. Suppose I am having iron deficiency anemia. So I take iron, na? Okay, suppose I am having insulin deficiency, diabetes. I will take insulin, na? So here the deficiency is dopamine, na ma'am? So give dopamine ka tablet or injection, whatever. But there is a little problem in this common sense. The common sense is good. But the problem is that dopamine cannot cross BBB. That is the problem. So we cannot inject it in brain directly, obviously. We have to give via blood. I mean, if you take a tablet, that will also absorb and go in the blood. If you give an injection, that will also go in the blood. Via any route, first it go in the blood. But from the blood, it cannot cross BBB. We cannot directly inject in the basal ganglion every day. We cannot do so. So that is the problem. Say, ma'am, then what is the solution? Again, use common sense. We can't use dopamine. I agree. But don't worry. There is a precursor of dopamine. The precursor of dopamine is levodopa. That can cross BBB easily. You say, ma'am, it's a good thing. You give levodopa only. You give levodopa. The levodopa will cross the BBB. Okay, once it crosses the BBB, it will reach the brain. In the brain, it's a precursor, no? It will convert into dopamine because it's a precursor of dopamine. It will convert into dopamine and whatever deficiency is there, that will be fulfilled. The life is easy. Okay, it's a very good common sense we have applied. We will give levodopa. But again, there is a small trouble in that. You say, what's the problem now, ma'am? You said ki levodopa can cross. Give the levodopa. Levodopa is the immediate precursor of dopamine. It will go, it will cross 100%, and in the brain, it will convert into dopamine. The deficiency will be replenished. Directly dopamine we cannot give, but the precursor we can definitely give in the form of tablet. Okay. But there is a little bit problem. Again, say, ma'am, what's the problem? The problem is that in the blood, we all have enzyme DDC. Okay. Decarboxylase enzyme. Okay. This is decarboxylase enzyme, DDC enzyme. Okay, this DDC enzyme convert the levodopa into dopamine in the blood only. Okay, so as soon as I give the patient a tablet, this is a tablet. Suppose I am a patient, I am taking a tablet of levodopa. That tablet is going in my mouth, in my esophagus, in my stomach, in my intestine. It will get absorbed, it will reach in my blood. So here is my tablet. 100% tablet is over here. But before it crosses the BBB, 99% of that is converted into dopamine. This enzyme is very fast. Okay, the coenzyme of this enzyme is vitamin B6, pyridoxine. Okay, I will tell the relevance of that. So this will act very fast and 99% get converted and it will remain in the blood only. It cannot cross the BBB. No? It cannot cross the BBB. That is the problem. It cannot cross the BBB. And intact levodopa only 1% is remaining. Okay, 99% is converted. That 1 to 2% will cross. Okay, so you will say, now it's a wastage. You are giving 100% and only 1% is crossing. The remaining 99% is converting in the periphery only with the help of enzyme DDC. That's problematic. And not only this dopamine will be high quantity in the blood. And from the blood, it will go on 3 organs. It will go on the human heart. On the human heart, there are dopamine receptor. It will go on the human blood vessel. On the blood vessel, there are dopamine receptor. And it will go on the third organ. What is the third organ? I will let you know. In the CTZ of the brain. The CTZ of the brain. The CTZ of the brain is not covered with BBB. So here it will lead to arrhythmias. Here it will lead to vasodilatation and fall in BP. The patient can go in hypotension, severe postural hypertension. And CTZ पे भी dopamine receptors are present. So it will lead to vomiting. तो ये तो double नुकसान हो गया. Number one disadvantage is that whatever levodopa I am giving 100%, only 99%, only 1% of that is showing the therapeutic action. 99% is wastage. It's not only wastage. The wastage is causing side effects. I need dopamine in the body. In Parkinsonism, I need dopamine, but dopamine in brain, not in my blood. There is deficiency of dopamine in the brain, in the basal ganglia, and I want to replenish there. I do not want to replenish in the blood. In bloods, it's normal. So we are giving levodopa, that levodopa doing peripheral conversion. That is the problem. Now use here again common sense. Now कोई लगाओ जुगाड़ कि ये सब ना हो. 100% levodopa can cross. Say, ma'am, why don't you give an inhibitor of DDC along with the levodopa? You give a combination, no? We have the tablet available. We have the drug available. The name of the drug is Carbidopa. Carbidopa. So we never gave levodopa alone. We gave levodopa with DDC inhibitor. Okay, this is the reason. So we gave levodopa with DDC inhibitor. The name of the drug is Carbidopa. So it's available in combination only. Single tablet containing both. So suppose I am the patient, I am taking the combination of levodopa and Carbidopa. Both are going in me. They are getting absorbed. They are reaching in my blood. In my blood, the Carbidopa is inhibiting DDC. Now DDC cannot convert levodopa to dopamine. The complete 100% levodopa will cross the brain. You are getting my point? And reach in the brain. People say yes. Say, got it? So it is reaching in the brain. Say yes. But in the brain also, the conversion of levodopa to dopamine is done by DDC enzyme only. No? So this is central DDC. This is peripheral DDC. I want to inhibit peripheral DDC, not central. If I inhibit both DDC, suppose, तो यहाँ भी convert नहीं होगा. Here तो we want the conversion, no? So that is the same story. Now imagine this. See this master chart. You will understand all 7 drugs over here. Appreciate my efforts. See, I have drawn this for you. Listen, appreciate it. So you can see here we are giving levodopa. Here is my drug levodopa. Appreciate it. Okay, levodopa can cross BBB. Appreciate. It can cross 100% to the BBB and reach the brain. Now levodopa is the precursor of dopamine, as I told you. Yes or no? So it is converted into dopamine in the periphery also. Periphery means, periphery se mera matlab hai blood. And it is converted into dopamine in the brain also. Okay, the enzyme is same. The enzyme is DDC. Here also DDC, here also DDC. This is the enzyme who is converting the levodopa into dopamine. Say yes. Okay, this is peripheral DDC. This is central DDC. So what I want for my patient, For my patient, I want this conversion should not happen. Okay, so that 100% levodopa cross the BBB and reach the brain. Okay, and I want this conversion to get happen. So that levodopa once reach the brain, it convert into dopamine and dopamine is replenished. There is deficiency of dopamine, no? That will be replenished. Okay, got it? Yes or no? So I will give levodopa with the peripheral DDC inhibitor, to be specific. Don't say DDC inhibitor. Say peripheral DDC inhibitor, not a central DDC inhibitor. We will give peripheral DDC inhibitor, that is carbidopa. That is carbidopa. That is the complete story. Okay. Dopamine cannot cross BBB. Okay. It is a levodopa which can cross the BBB. And dopamine, once formed in the blood, it will act on 3 organs. What are the 3 organs? Heart, blood vessel, and CTZ. On the heart, it leads to arrhythmia. On the blood vessel, it will lead to vasodilatation and hypotension. And on CTZ, it will lead to vomiting. So suppose we are giving alone levodopa. We are not giving carbidopa. We are giving alone levodopa. So patient will not have effect in Parkinsonism. Patient will have same Parkinsonism. It will not be cured. It will not be treated, I mean. And patient will have 3 symptoms. That patient will have arrhythmia, patient will have hypotension, and patient will have vomiting. है ना? एक तो disease ठीक नहीं हुई, ऊपर से 3 side effect हो गए. So never give levodopa alone. You are getting my point, people? Yes, no, say something. I will scold you now. So let's start it. I have started the first drug. The name of the drug, the name of the category is dopamine precursor. Now you are understanding the name also. It's a dopamine precursor. It is a precursor of the dopamine. The name of the drug is levodopa. It's a dopamine precursor. It's not dopamine. Okay, levodopa. So say what you will write in the introduction. Dopamine itself cannot cross BBB. Dopamine itself cannot cross BBB, but its precursor, that is levodopa, can cross the BBB. Levodopa is inactivated in the periphery only. Okay. Levodopa is inactive by itself. Okay. Levodopa is inactive by itself and it converted into dopamine and show the action. Okay. It is the most commonly used drug in Parkinsonism. I'm not saying it's drug of choice. It's not drug of choice for Parkinsonism. It's the most commonly and most effective drug in Parkinsonism, but not drug of choice. I will let you know what is drug of choice. But if I'm giving levodopa alone, okay, in the periphery, we have an enzyme DDC. What is DDC? Dopa decarboxylase. The full form of DDC. Dopa decarboxylase. The peripheral dopa decarboxylase converting levodopa to dopamine in the periphery only. This conversion is taking place in the periphery as well as brain. We are having DDC at both places. Appreciate. We are having DDC in the periphery also, brain also. But before it entered in the brain, in the periphery only it got converted. Okay, so peripheral conversion. So if I am giving a 100 milligram tablet of levodopa, so 95% of it is converted in the periphery only with the peripheral DDC. Okay, and dopamine is formed in the blood. Okay, and only 1 to 2% is entering in the brain and showing the therapeutic effect. In the brain, it is converting into dopamine and showing the effect. But in the blood, the dopamine is not good. In the brain, it is treating the Parkinsonism, but in the blood, it will cause 3 side effects. So the dopamine receptors are present on the heart, on the blood vessel, and on the CTZ. So on the heart, it will lead to arrhythmia. On the blood vessel, it will lead to vasodilatation. And in the brain, in the CTZ, it will lead to vomiting. So patient will have arrhythmia, postural hypertension, and vomiting. Because the peripherally formed dopamine will act on heart, blood vessel, and CTZ. And only 1 to 2% is entering in the brain, which is converting into dopamine and treating the Parkinsonism. Got it? Can we go ahead? People respond. Say, shall I repeat it? In general, how will I know it's periphery or it's brain? How will I know means, Kanu, I didn't got your question exactly. Okay, I didn't got your question. So if we are a doctor and we are giving the patient a tablet of levodopa, before it enters the brain, in the blood only it get converted. And if you are asking for this diagram, I have labeled, Kanu, this one is periphery, this one is brain. I have labeled. And if you are asking in human body, peripheral conversion takes place before it enters the BPB. I didn't kindly elaborate your question. Okay, so I will read it, Sunita. Here only you can see, you can concentrate. Okay, exactly what is the query you are asking? Carbidopa is peripheral DDC inhibitor. Rakesh, very good question. Carbidopa, you can see, carbidopa and benzerzide. We commonly use carbidopa and benzerzide. Both of them are peripheral DDC inhibitor. Appreciate the negative sign. Okay, so we give levodopa along with carbidopa or along with benzerzide. These are known as peripheral DDC inhibitors. Appreciate this diagram. I'm explaining once again. Okay, yes, you are right, Rakesh. The carbidopa and benzerzide, they cannot cross BBB. That's why they cannot inhibit the central DDC. They are peripheral DDC inhibitor. So they inhibit only this DDC. They do not inhibit this DDC. So this DDC is inhibited. That's why levodopa remain levodopa in the blood and it will cross the blood-brain barrier. and it will reach the brain. Once it reaches the brain, there is no inhibitor of DDC. It will convert it into dopamine, and the dopamine deficiency will be replenished. And this is how we are treating our patient. I will not say curing. It's not a cure. It's a symptomatic relief. People say, got it. What is your query, Sunita? Can you elaborate? I will be able to explain it faster if you elaborate your query. Kanu, I didn't got your query also. You can elaborate it if you wish. Okay. So suppose I'm having a patient in my clinic who is an old man, the grandfather age man, and the person is having Parkinsonism, the typical triad of Parkinsonism. Being a doctor, I want to treat it. Suppose I'm a neurologist and I want to treat my patient, obviously. Okay, so if I'm using common sense, why the person is having Parkinsonism? In the brain of this human, inside the basal ganglion, there is deficiency of dopamine. So common sense, I have to replenish the dopamine. Say, ma'am, dopamine ka tablet, dopamine ka injection. I will give tablet or injection of dopamine. So dopamine tablet will go in blood, dopamine injection will go in blood, but dopamine cannot cross BBB. What is the use? I want to replenish dopamine in the brain, not in the blood. So there is no use of giving dopamine tablet or dopamine injection. No, we cannot do that. So say, ma'am, then what is the solution? Dopamine cannot cross BBB. I cannot inject it in the basal ganglion directly daily. I cannot do so, obviously. So tell me some alternative. Say, ma'am, give the precursor of dopamine. The precursor of dopamine is levodopa. That can cross the BBB. The problem is solved. So give a tablet. It's available orally. Give the tablet of levodopa. So suppose I am the patient. I am taking levodopa. It's going inside. It gets absorbed. It reaches in my blood. But before it crosses BBB, it converted into dopamine in the blood only. So same problem. So we do not want this conversion to take place in the blood. Okay, suppose it is converting in the blood, 99% it convert here only. Only 1% it will cross. So therapeutic effect will be very less. Number one. And once it is converted into dopamine in the blood there is high concentration of dopamine that will act on 3 organs: heart, blood vessel, and CTZ. That will lead to 3 side effects: arrhythmia, vasodilation, that is hypotension, and vomiting. So imagine if I am a bad neurosurgeon. Okay, I don't have all this knowledge and I am giving plain levodopa to my patient. So my patient will not have any effect on the disease. My patient tremors, rigidity is still same. And patient started vomiting also. Patient is having arrhythmias also. And patient is having hypertension also. So disease तो मैंने कुछ ठीक की नहीं. 3 side effect और दे दिए. So I cannot use plain levodopa. Okay, I cannot use plain levodopa because only 1% is crossing. Okay, 99% is giving the side effect by converting into dopamine. So we have to find a solution of this problem. So give peripheral DDC inhibitor along with the levodopa. Okay, so along with levodopa, we give carbidopa or banserzide. These are peripheral DDC inhibitor. They cannot cross BBB. They remain in the blood only and they inhibit DDC enzyme. So we give the combination tablet. Okay, so suppose I'm taking the tablet of levodopa plus carbidopa. Both of them will go in my blood. So carbidopa will inhibit my DDC. Since my DDC is gone, now levodopa remain levodopa only. It will not convert into dopamine. Before DDC convert levodopa to dopamine, DDC is inhibited by carbidopa. Now this levodopa will cross the BBB and it will reach in the brain and the patient will have the symptomatic relief. Okay, in the brain, this levodopa is converted to dopamine by DDC because this DDC is not inhibited. Carbidopa and benserzide are inhibiting peripheral DDC. Crystal clear. What else shall I tell you? I have repeated 3-4 times. Okay, this is the complete thing. So peripheral conversion is harmful. There are 4 disadvantages of peripheral conversion. Ek to therapeutic effect is less. Only 1% levodopa is crossing. And the remaining 99% is giving 3 side effects. Okay, 1 on the heart, 1 on the blood vessel, and 1 on the CTZ. Arrhythmia, vasodilation, hypotension, especially postural hypertension, and vomiting. So these are the 4 disadvantages of peripheral conversion. We do not want peripheral conversion. So these are the 4 disadvantages. You can see. Number 1, only 1 to 2% is crossing. So therapeutic effect is very less. So 99% is wastage. Okay, not only wastage, that wastage is causing side effect. The 3 side effect. You can see heart mein arrhythmia, blood vessel mein postural hypertension, CTZ mein nausea, vomiting. You got it. Okay, so we have to overcome the peripheral conversion. How we have overcome the peripheral conversion? We have given peripheral DDC inhibitor. Peripheral DDC inhibitor like carbidopa or banserzide. So we give a combination, either levodopa with carbidopa or levodopa with banserzide. This more commonly used. This also we can use, but more commonly this one is available. So it is known as carbi-levodopa. Okay, we give this combination. We don't give plain levodopa. No, never. इससे अच्छा तो ना दो. Okay, don't give anything. Okay, so instead of becoming a bad doctor, don't be a doctor. That is the thing. So don't give levodopa alone. Either give in combination or don't give it at all. Since you are giving alone levodopa, you are killing your patient instead of treating it. Okay, not you. I mean any doctor if it is doing. So we don't have to give levodopa alone. We have to L-dopa therapy. Okay, I'm sorry, we have to add carbidopa to the levodopa. We have to give the combination. Combination will increase the entry of levodopa to the brain, number one. Okay, peripheral conversion will not be there. And since the peripheral conversion is not there, it will reduce the 3 side effects of the dopamine. Okay, so basically this conversion is inhibited. So this dopamine will not form. So it will not act on heart, blood vessel and CTZ. So patient don't have arrhythmia, patient don't have hypertension, patient don't have vomiting. The problem is solved. Done, 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 done. Okay. So this is the complete story in the introduction only and in the mechanism of action I told you. Anyone have any confusion? Mechanism of action ab bataungi. Introduction mein this was the complete story I told you. So I'm teaching you the first category. I will teach you 7 categories of drugs in the disease Parkinsonism. The first category I started, naam mein hi hai, dopamine ka precursor. There is only one dopamine precursor, levodopa. In the introduction, you have to tell complete story. In the complete story, you have to tell dopamine cannot cross BBB. So we have to give the precursor. The precursor is levodopa. Levodopa can cross, but the problem is that it's peripheral conversion. In the periphery only it converted to dopamine. And again, dopamine cannot cross. That is the problem. And dopamine will cause side effects on the 3 organ. So we have to inhibit this conversion. The enzyme is DDC. So we have to give DDC inhibitor along with the levodopa. That is carbidopa. So you have to tell the disadvantages of conversion and how to overcome the conversion. You have to tell all these things in the introduction. Introduction was quite long and interesting. Yes. So in the introduction, write down the complete story. After that, coming on mechanism of action. Once the dopamine reach the brain, okay, so we are giving the combination of levo plus carbidopa. Okay, as soon as this combination is given, the carbidopa will act. Suppose I am taking a tablet which contain both. I am having Parkinsonism. Okay, that tablet will go get absorbed, reach my blood. So my blood have this also, this also. This carbidopa will inhibit my DDC enzyme in my blood. My DDC enzyme is not functional now. Okay, so levodopa will not convert into dopamine. It will remain in blood only, and levodopa can cross BBB. It will reach in my brain. In my brain, complete 100% levodopa will reach. Okay, and levodopa will be taken up by the dopaminergic neuron. Inside the neuron, levodopa convert into dopamine because the brain DDC is functional and dopamine is restored. Okay, the problem is solved. So again, we achieve a balance between the dopamine and the acetylcholine. Acetylcholine was normal, but the dopamine was reduced. So we have again achieved the balance by increasing its concentration. So there is smoothing of the movement and symptomatic relief. I'm using the word symptomatic relief because I have not permanently cured the disease. Okay, so till the patient is taking levodopa, the dopamine will be replenished. So patient have to take it daily. It is not once for all cure ki 7 din ka course hai, kar lo, uske baad nahi. So it is throughout the life. Every day patient have to take this combination. Every day till death. Yes or no? You are getting my point. Like the person who is having diabetes. What is diabetes? Insulin deficiency. So the person who is on diabetes and person is taking artificial insulin injection. Okay, insulin is a form of injection. Person has to take it throughout the life. It is not for 5 days, 7 days, 10 days. It's a course of antibiotic like. No, no, no. So some diseases are incurable. It is one of them. We are not curing. So endogenous synthesis of dopamine is not occurring. We are replenishing it from outside. Okay, in the form of its precursor. And we have to replenish throughout the life. Yes or no? But there is a problem. It's a very complicated disease. It's not that way simple. People, we are understanding. It's very bad disease actually. I will explain. Okay. Do you have any confusion till now? Otherwise, each and every one of you show some interest, show some energy. You got it? I taught you 1 out of the 7 drugs. I taught you 1 till now. Levodopa. I have explained completely. Yes. Okay. So we have seen its classification. We have seen its introduction. We have seen its mechanism of action. Now coming on actions. Actions I will teach you on 4 organs. You have to tell me the actions of levodopa on CNS, CVS, CTZ and endocrine. 3 you already know. What happens on CNS? What will happen on CNS? If we are giving levodopa, what the levodopa is doing in the CNS? In the CNS, levodopa act on D1 as well as D2 receptor. I told you, there are 2 types of receptors, D1 and D2 in the brain. You don't have to understand this complex pathway which is present in the brain. But yeah, dopamine will be replenished in both of them. And ultimately, the net effect is smoothing of the movement. I mean, the dopamine deficiency is replenished. Okay. And it is equal to acetylcholine. Dopamine and acetylcholine become equal and there is smoothing. So smoothing mein patient was having triad. Patient was coming to the clinic with 3 complaints. Doctor, I am having tremors. Tremors on breast. On activity or on sleep, they disappear. But on breast, I am having the tremors. I showed you a video. Okay. Doctor, I am having rigidity. Okay. The passive movements, on passive movements, there is resistance and hypokinesia. The initial part of the movement is slow and later part is fast. That is hypokinesia. So if we start the patient on levodopa, first of all, hypokinesia will recover. Okay, then patient's rigidity will recover. Tremors are last to recover. So you have to learn the mnemonic HRT. Okay, you can learn the mnemonic hormonal replacement therapy or whatever. HRT. So first hypokinesia followed by rigidity followed by tremor. So first of all, patient hypokinesia will improve. Patient will feel better. Then gradually, if you continue the course of levodopa daily, after few days, few weeks, patient will see the improvement in the rigidity. And after some time, patient will see improvement in the tremors and patient is happy. And later on, the secondary symptoms will also improve, like the posture, gait, handwriting, facial expression. I told you, in Parkinsonism, patient have ekdam mask-like expressions. Patient don't show any expression like you people. You people don't give me any expression over here. That's why I'm saying, okay. So patient have again regainment of the expression, the mood, self-care, interest in life, everything will be regained. So levodopa is a very good drug. Say, ma'am, it's a very good drug. Why don't we give it to the patient throughout the life? The problem is solved now. Yes, but there is a problem. I will let you know what is the problem over here. Listen. So therapeutic benefit is nearly complete in the early disease. For 3 years, the life is very good. Okay, we started it, patient is feeling very good. सबसे पहले hypokinesia is improved. Okay, then rigidity is improved. Then tremors is improved. Then gait is improved. Okay, facial expressions is improved. The lifestyle is improved. Patients start taking interest in life again, and everything is smooth. Smoothing of movements. Everything is nearly normal for 3 to 4 years. After that, again there is a problem. Okay, levodopa has altering response on the behavior. So gradually levodopa in the brain, what it is doing? Levodopa in the brain, it is increasing dopamine. So after 3 to 4 years, if the patient is continuously taking the levodopa, after 3 to 4 years, there is excessive of dopamine in the brain. That will lead to behavioral changes and patients start behaving like a mad person. Okay, then we have to judge whether these symptoms are better or whether madness is better. So we have to off dopa or on dopa, that will be a call after 3 to 4 years. And we can extend for 3 to 4 more years. Okay, so life after Parkinsonism is difficult. For the first 3-4 years, it's good till the levodopa is working. But after that, once the levodopa causing excessive dopamine in the brain, we cannot manage it. So that situation is aage kuan piche khai. In English, I don't know what it has to be said. Okay, so I mean, if we don't give the treatment, patient will have the these three symptoms. And if we give the treatment, patient will have mental symptoms because of excess of dopamine. So that call have to be taken. Sometimes patient can be frank psychosis, the complete. I will show you in the adverse effects. So that is the problem. Okay, that is the problem. That is the effect on the CNS. We have seen the effect on the CNS. Initially, the effect is good. First H response, then R response, then T response, then secondary symptom response, and it is for 3 to 4 years. After that, dopamine excess is there. Then behavioral changes occur, and finally, frank psychosis if we don't stop the therapy. This is the complete spectrum on the brain. Okay, now come on CVS. Second is CVS. What is happening in the heart? I mean, CVS mein heart or blood vessel, you already know. If the peripheral conversion taking place, okay, we are giving levodopa alone without carbidopa. So it will convert into dopamine. It will convert into dopamine in the blood only. Okay. And that will act on the heart, leading to arrhythmia. That will act on the blood vessel, leading to hypotension. We already know that. In the heart, dopamine receptor, having arrhythmia. In the blood vessel, dopamine receptor, leading to postural hypertension. CTZ, we already know. Okay. Dopamine active. CTZ is outside the BBB. Okay, dopamine cannot cross BBB, but dopamine can go to the CTZ because it is outside BBB. It can get access to CTZ without any hindrance, and patient will have nausea, vomiting. This we already know. On the endocrine, levodopa will go inside, and levodopa act on the pituitary. On the pituitary, it act on mammotroph and somatotroph. These are the cells of pituitary, I guess you know. So it decrease prolactin and increase growth hormone. From the pituitary, prolactin also secreted, growth hormone also secreted. So patient on levodopa have less prolactin and more growth hormone. Okay, so prolactin will be less, growth hormone will be more. So say the action, we are done with the actions also. People be fast. Say, keep up with my speed. Chalo, batao. CNS pe what is the action? See ma'am, initial actions are good. First, what do you call? Hypokinesia respond. Then rigidity respond, then tremors respond, then secondary symptom may gaits, facial expression, lifestyle, everything will respond. Patient is very happy, but the happiness is not longer. It is for 3 to 4 years. After that, dopamine access in the brain, and that will lead to psychosis. Okay, I will teach you antipsychotic drugs tomorrow. Tomorrow's session is super duper interesting. So antipsychotic, antidepressants, anti-mania. Okay, all these drugs we will see tomorrow. Anyways, psychosis, sometimes frank psychosis. Okay, now at that time we have to weigh, we have to stop levodopa or we have to continue. If we stop, patient presents with this. If we continue, patient presents with this. Both are bothersome. Both are bothersome. Yes. Aage kuan, piche khai. That is the situation after 3 to 4 years. We can extend 3 to 4 more years after that person dies, usually. Okay, in most of the cases. So that is a normal situation in CNS. Coming on CVS. In the CVS, if we are giving levodopa alone without carbidopa, it will convert into dopamine in the periphery only. Okay, it will convert into dopamine in the periphery because of the enzyme peripheral DDC, and that will act on heart and blood vessel. On the heart, it will lead to arrhythmia, blood vessel pe vasodilatation and hypotension. CTZ. Okay, CTZ may levodopa convert into dopamine, and dopamine can go on the CTZ and cause vomiting. Endocrine may levodopa go on the pituitary. In the pituitary, decrease prolactin and increase growth hormone. Done. Okay, that is the actions. In short, I told you. You have to elaborate each of them. Classification में only one drug, levodopa. Introduction में you have to tell the complete story why we can't give levodopa alone. We are giving levodopa along with carbidopa. Okay, I mean peripheral DDC inhibitor. Okay, so that you have to say. My next drug is peripheral DDC inhibitor only, which I am teaching you here only. This carbidopa, my next category. Because we don't give this alone, we give this along with this. So these two are given. So basically we are covering two drugs together. Yes. Mechanism of action I already taught you. The mechanism of action of the combination. Okay, actions on 4 organs I already taught you. What is the action on CNS? What is the action on CVS? What is the action on CTZ in the brain? And what is the action on endocrine? You already know, on the pituitary. Coming on pharmacokinetics. The next heading is pharmacokinetics. Pharmacokinetics of levodopa, unfortunately, you have to learn. Isme kya hai? It undergo high first pass metabolism. First pass metabolism is high. T half is 2 hours. Okay, it is metabolized, you already know, no? It is metabolized by peripheral DDC and it is converted into... Hello everyone. I hope you found this concept clear and easy to understand. If you would like to dive deeper into this topic and master it with full-length lectures, you can subscribe my app, that is MedLife by Dr. Priyanka. So, join me for the live sessions where we break down the complex topics in a way that makes them simple and high yield for exams. See you inside.